Assalamu alaikum, sir. Yes, sir.
You can start.
Sir, my today's presentation is about the secondary preventions in the asymptomatic carotid artery disease. The components of secondary preventions are: one, optimal medical therapy, screening for asymptomatic carotid stenosis, and intervention in asymptomatic patients. Class clarity. This is just to define what am I going to define the classes and what they means. The class 1 means the benefit is more than risk and should be done. Class 2A, the benefit is more than risk, but additional studies with focused objectives are needed in it. Class 2B, benefit is more than risk, but additional studies with broad objectives are needed. And class 3 means there are no benefit of doing it. Optimal medical therapy. Optimal medical therapy consists of risk factor control, antiplatelet therapy, lipid lowering therapy, hypertensive management, diabetic management, adherence to the optimal medical therapy, risk factor control. The risk factor control basically consists of a healthy diet, smoking cessation, optimal body weight, and obesity management. Physical activity, they are all classified as class 1B recommendations. That means they should be done for the risk control assessment. Antiplatelet therapy, although there is a conflicting opinion regarding the antiplatelet therapy in the asymptomatic patients, as it increases the risk of major bleeding events. But the patients having pre-existing aspirin, low dose 75 to 325 mg is recommended as a first-line agent because it reduces stroke severity at presentation, improves functional outcome at discharge, and prevention of late myocardial infarction and other cardiovascular events. These all are classified as class 1A. Clopidogrel 75 mg daily should be considered only if the patient is aspirin intolerant. This is classified as class 2A. Lipid lowering therapies. The evidence-based treatment goals for studies have advised high-intensity statin treatment goals, including a low-density lipoprotein level of less than 1.8 millimole per liter or 50% reduction by either 40 to 80 mg atorvastatin or 20 to 40 mg rovastatin. Statin therapy is recommended for a long-term prevention of stroke, myocardial infarction, and other cardiovascular events. Hypertensive management. Antihypertensive treatment is recommended for patients with hypertension and asymptomatic extracranial internal carotid artery stenosis to maintain long-term blood pressure of less than 140 by 90 mmHg. Calcium channel blockers reduces the intima media thickness progression more than diuretics, beta blockers, or ACE inhibitors. In a Chinese study of randomized control trial, hypertensive patients without a history of stroke on MI, enalapril plus folic acid versus enalapril alone reduces the risk of first stroke. European Society of Cardiology or European Society for Hypertension advised that the target for end diastolic blood pressure should be 85 mmHg in patients with diabetes. Diabetic patients. Diabetes doubles the risk of stroke. In diabetic patients with asymptomatic carotid stenosis, strict glycemic control is recommended, and the target blood pressure should be less than 140 by 85 mmHg. These both are classified as class 1. It means it should be done. Adherence to the optimal medical therapy. Survival is significantly better for the patients who remains adherent to the best medical treatment. But there are some predictors for the poor compliance, which includes undiagnosed cognitive impairment, psychological problems, especially depression, asymptomatic disease, inadequate follow-up or discharge planning, presence of barriers to care or medications, medication side effects, missed appointments, complexity or cost of medication, patients' lack of belief in the benefits of medical treatment, lack of insight into the illness, and poor provider-patient relationship. Now, the screening for the asymptomatic carotid stenosis. Routine population screening for asymptomatic carotid stenosis is not recommended, although this is classified as class 3C. Selective screening may be considered in patients with multiple vascular risk factors to optimize risk factors control and medical therapy to reduce the late cardiovascular morbidity and mortality, rather than for identifying candidates for invasive cardiac carotid interventions. This is classified as class 2B. Interventions in asymptomatic patients. consists of two methods: carotid endarterectomy and carotid stenosis. Stenting, sorry. Criteria in a higher risk for stroke patients for revascularization is either the patient have one or more clinical features or have imaging features such as silent infarct on CT or MRI, stenosis progression, large plaque area and its echolucency, large juxtaluminal black area on computerized plaque analysis, intraplaque hemorrhage on MRI, impaired cerebral vascular reserve, spontaneous embolization on transcranial Doppler monitoring. Recommendation for interventions. In average surgical risk patient with an asymptomatic 60 to 99% stenosis should be considered in the presence of one or more imaging characteristics, which was defined previously, that may be associated with an increased risk of late ipsilateral stroke, provided documented perioperative stroke or death rates are less than 3%, and the patient's life expectancy exceeds 5 years for either carotid endarterectomy class 2A and carotid stenting class 2B. Criteria for carotid stenting. Carotid stenting may be considered in selected asymptomatic patients who have been deemed by the multidisciplinary team to be a high risk for carotid endarterectomy, provided documented procedure risks are less than 3% and life expectancy exceeds 5 years, and having 70 to 99% stenosis in the presence of one or more of the following: carotid cardiac disease such as congestive heart failure, abnormal stress test, or need for open heart surgery. Second, contralateral laryngeal nerve palsy, cervical radiation therapy, recurrent stenosis after carotid endarterectomy, severe pulmonary disease, contralateral carotid occlusion, previous radical neck surgery, and if the patient's age is more than 80 years. Carotid revascularization to prevent dementia. Until a causal association between a severe asymptomatic carotid stenosis and a cognitive decline has been established, carotid interventions are not recommended for the prevention of cognitive impairment in patients with severe asymptomatic carotid stenosis. And last, there's this diagram, a flow chart to show all of the treatment plan in asymptomatic and symptomatic patients. My focus was on asymptomatic patients. So in asymptomatic patients, as it is, the carotid stenosis ranging from 60 to 99%. If life expectancy more than 5 years with favorable anatomy and less than or near to one feature suggesting higher stroke on risk on BMT, the patient should be considered for either carotid endarterectomy or carotid artery stenting. If there are no such things, then best medical treatment is the best method. Thank you, sir. Any questions?
Yeah, Saqib, that was very good presentation. And the key message from your presentation, which I find, is that best medical therapy has to be adopted in this patient, and that decreases the risk of the stroke. And secondly, intervention in asymptomatic patient is a selective one. You have rightly identified the patients both on clinical basis, on the radiological basis, that can be selected for selective intervention, and intervention is not offered for all the patients. I will like the comments of the participants, and any questions from there, they can raise the hand and we can join. This is very important topic, because in every clinic we get a patients who have an ultrasound report which shows some degree of stenosis, and the practices may vary. Yeah, I see that there's still a lot of silence, but I suppose you have rightly said that radiological criteria is very important, and the most important is identifying the vulnerable plaque, and that can be done on the ultrasound, CTA, but MRA is a very good investigation to identify it. The most important is PET scan,